Uh, Good afternoon, Dean Wolff, and thank you for making the time in your busy schedule to share your thoughts with us on this podcast discussing impact of oral health on patients' well-being. With that, I want to start by saying how long I know you. I've known you for over 18 years, and we worked closely the last 12 years. It's probably one of the best of my career. We worked on multiple projects in the dental field, obviously, oral health, teaching, implementing the electronic dental records, and you've been amazing on putting it together when we worked together at NYU. And most importantly, I witnessed your rise to lead one of the most prestigious dental schools in the nation and moving it to the next level. I've been with you 2 years over there. It's really fascinating to watch. With that said, I can't interview a better suited person to discuss the impact of oral health on the well-being of human beings other than yourself. So with that, I want to share first a story that starts the first question. You were kind last time to offer me a ride from Philadelphia to New York when you were in New York and I was going to teach. And as you're always busy and committed. You took a Zoom meeting while we were on the ride, and I heard you talking. And one of the words, that's what basically started me asking you for the podcast. You said something that still resonates in my head. Oral health has a great impact on the success of a person in their career. Would you like to elaborate on that? Because I spoke with you on it, but I want to hear it from you to the audience.
So first, just to protect my auto insurance, I was only on the audio portion
Indeed, yes.
of the Zoom.
Yeah.
But yes, you were in the car as I was on the Zoom as we were speaking about this. So there are a number of things that are interesting about this. It's just within the last several years, decade or so, that everybody started recognizing there's a social value to oral health in all respects, and that's wonderful. Now, we know that there's a social value because as humans, we're attracted to each other. And one of the things that occurs with that is it's actually a smile that grabs us, and actually it's that expression on the face, it's the happiness, it's the contour, it's all part of where we are. Our teeth help us communicate, they help us eat, but they also help us in a large respect with self-esteem and that initial non-verbal communication. How do we get that information to each other? And a good deal of it comes out of what we look like and what we smile. There's actually been some research done that one of the key determinants on getting jobs, for instance, turns out to actually be associated with that smile and what you look like. That first impression is not only what you're wearing and how you look, but it's how you smile and that friendliness that's conveyed from our teeth. And that's pretty amazing. And you know, the great thing about being a dentist is so frequently we walk out the door, a patient walks out the door, and it's there. You look at them and you realize, you know, you've helped make them smile, numb or not. They're feeling good about everything that they just went through. So it helps us in so many different ways. Our personal psychologies, our self-esteem, but more than that, to the outside, how other people judge us is often through our smile, that job interview, that initial interaction. I had some experiences globally in tooth decay studies. And there are things that, you know, when we see a young child losing a front tooth due to tooth decay, we know immediately, no matter how bright that child is or where they're going in their education, they're going to go uphill trying to get that job. Especially if that job has them as a forward-facing individual, that they're in the community, they're at the front desk of a hotel, they're in restaurant. Nobody wants to stare at somebody without their front teeth.
Yeah, yeah,
Um,
that's exactly the point. Economically, it has a big impact, and
Yeah. Yeah.
and that's one of the things that we're going to discuss quite a bit at the end in it. So, having on that same segue, there's a saying: "The mouth is the gateway to your body." What do you think about this saying, and that will lead us to others?
Well, I think you can't be, I see so many people that spend tremendous amount of time in the gym, exercising, working out, trying to be healthy, eating healthy food. You can't be healthy without having a healthy mouth. It's certainly a cornerstone of our health. It helps us, as I said, in communication and eating and everything else. But it's actually more than that. Red bleeding gums may be a local event of gum disease and lack of oral health, or it can be a sign of a greater issue. I'm not saying cause and effect. Gum disease causes diabetes. Gum disease causes heart disease or stroke. But what's remarkable is gum disease is found in higher incidence in persons that have heart disease, that have had strokes, that have. Now, we do know that in aging populations that are seen in hospitals, they have pneumonia that has oral bacteria much more frequently in patients that have periodontal disease. And we're just now, it's important not to overstretch this relationship between body health and oral health, but it's also important not to underemphasize. There is a relationship to the amount of inflammation we see in the gums and the amount of inflammation we see in the bloodstream. We know people that have periodontal disease have a harder time controlling their diabetes.
Correct.
Once again, not cause and effect necessarily.
Yes. It's a
but something is functioning that's causing both. And the other aspect is we know that people that have diabetes have a harder time keeping and maintaining oral health. They struggle to make that happen. So, it's remarkable and wonderful that we're starting to understand this. And it goes a long way to understanding it goes a long way to understanding why universal health care has to include oral health as part of that. Especially as we age and develop more diseases and have more problems, oral health becomes more important in making us have healthy outcomes throughout. And it's just absolutely critical.
Yeah, I mean, it's actually in the continuing on that point. Basically, it is kind of a comorbidity, the periodontal disease,
Exactly.
and we've seen it with COVID that it attaches to the oral cavity basically, and if you have periodontal disease, it increases in the bloodstream, and we've seen something important also that in early deliveries. Of premature deliveries or low weight
low birth weight.
Yeah, and that there is a correlation between the periodontal disease and that. So the biggest problem that we are facing, we know it, there is studies been talking about it, we had a lot of conversation about it, but how can we get this message out? Because recently, and I'm that's the beauty of a conversation. We change the stream of the questioning or the interview, but you encouraged me to pursue that dual masters in healthcare leadership and in MBA, and in it I was fascinated that physicians did not hear about that subject of birth rate, the low, the premature deliveries or the weight of the birth,
Yeah.
that they never heard of it. So how can we? I don't know, as a dentist, as academic institutions, as a organized organization of dentistry are not doing the job, or what do you think? How we can improve on that?
So I think we have to go back to the history of oral health care in education,
Yeah.
in the United States and Europe. They essentially were not co-educated. We educated separately and came through two pathways that resulted in dentistry. The body starts at the tonsils and goes backwards for the primary healthcare provider, and dentists just looked at teeth and didn't, as a matter of fact, even the word dentist is associated with Latin for teeth. Not oral healthcare provider, not oral physician. Teeth. It's more than teeth. And for the primary healthcare provider, it's not only social workers, teachers, dietitians, nursing and physicians all get to look inside the mouth, either brief glimpses or thorough glimpses, and can have some idea about oral health issues. But for some reason, we didn't get into the healthcare education arena as oral, specialists. And, in dentistry, we've had a problem getting enough interface of medicine into what we're doing in dentistry. Our two professions essentially grew divergent instead of parallel or together. I think today we have no choice but to look at other workforces. How could a child have a tooth that has black on it and still have a physician or a nurse practitioner look inside there at the tonsils and ask the child to go and not say anything? We have to, as professions, everybody's got to look under the tongue to see if there's an oral cancer. Dentists have to talk about why HPV, human papillomavirus, which is commonly thought about as a venereal disease in transmission, but we have to talk about that as a cancer preventive. Not only talking about cancers of the cervix, for women, but it's the most common correlate to oral pharyngeal cancer. So we do have to figure out how to make these a joint agenda. Dentists talking about, but I deal with a lot of older patients, or I used to. Now that I'm a dean, I do a lot less practice. But when we talk to older patients, why aren't I talking about flu vaccination? Flu was, prior to COVID, flu killed more people over the age of 65 than just about any, other contagious disease. And yet the vaccination almost eliminated the risk of dying from flu. Now we're post-COVID, there's a whole world around that, but we can do better as a dental profession about thinking about the patient's whole health. And we need to work with our healthcare providers to make oral health an important part of it.
Yeah, and that is actually a very very important point, because if we look at the other part that I've been dealing with or learning is it's the economics of the cost of healthcare. You know, in the healthcare there is what they call the iron triangle. How can you give them more access, reduce the cost, improve the health treatment? But yet we know that as a comorbidity from everything, emotional, infectious, inflammatory, everything, can we help them? And it will have an impact also on healthcare cost. So with that, you know, once we were having you know, the lunch that we do sometimes, and we talked about how can we get the states or the federal government or thinking differently also.
Yeah.
And one of the things that you brought up and we were having the conversation is that, you know, one of the governors that you were visiting, he told you, show me basically the money, show me how we can save it. And that was fascinating, that they haven't put the two together, because for him as an administrator, basically, he's not seeing where I can save money for the healthcare cost of his budget. But yet we know that if we improve the oral healthcare, we can reduce the comorbidities and so on and so forth. So what do you think about that
So,
also?
yeah, that was Governor Steve Beshear, the former governor of Kentucky,
Yeah.
that we've involved actually in helping in some dental policy development. So we opened, since I'm here at Penn, we actually opened a Center for Global Policy for in oral health, particularly. And, you know, as you know, I've spent a lifetime working in tooth decay and trying different toothpastes and methods of reducing decay. And I've run some pretty large studies and some pretty small studies on it, on patients. And he said to me, you know, so tell me in 2 minutes, you know, why should I invest in this toothpaste event? And I went through a diatribe that was much longer than 2 minutes, talking about, well, we can reduce 73% of the new tooth decay if you do this and you do that and you do that. He says, what does 73% of anything mean to me?
Yes.
Can you tell me how much money it's going to save? Tell me how many days of school will be gained by children staying in school. Tell me how many fewer days of sick leave will be used for toothaches. Can you tell me how many days of sick leave are used for toothaches right now?
Mm.
I said, wow, no. He says, well, if you can tell an employer how much more appealing a salesperson will be with straight teeth, how much more appealing a salesperson may be with white teeth, how much more work can be done with somebody that doesn't have a toothache, how much better a child may study if their teeth don't bother them. And he went down a litany of these things that as a dentist, I had never, as a dental researcher, I had just never thought about these outcomes as being important. And to our policymakers, the people that control the checkbook on whether or not dentistry will be a covered process or this, it was lost upon me that we can do a lot better than this and actually develop a series of talking points that are truly based on what we can save economically by doing dentistry and keeping mouths healthy. How many extra days at work? How many fewer days out of school can we improve? Can we improve the likelihood of Mark Wolff getting hired when he goes for a job interview if his teeth are nicer or whiter or he has a better smile? There's a whole realm of psychologic research on self-esteem. Can you reduce depression? Can you improve self-esteem on a person by by making them happy looking at themselves in the mirror.
We know it that it is a fact, but unfortunately, as you mentioned, there's no studies about these things.
Correct.
We talked about correlations, comorbidities, not the direct effect, but as an additive effect. But we never talked about the mental health, and we know now, right now, mental health is one of the biggest problems we have in the United States, especially after COVID. For some reason, it exploded. So on that, do you think I mean, I used to be a full-time academician before, but I still consider myself an academician. So in your thank you, thanks to you for inviting me. But in reality, how can we as academician or people of influence in the dental society influence the dentists themselves also, and the communities around them? A position like yourself as a dean, how do you think we can, what you mentioned right now, have an impact on it, bring it up to people get interested in doing these studies?
So I think that the agenda is changing, Edgar. We're getting to a point of discussion where industry is recognizing how to support the efforts of changing policy. Fluoride went into the public water supply for the first time in Grand Rapids in 1945, I think was the 45, could be 46. And then it went into toothpaste in the 50s. And there was this tacit assumption that in the 60s, all things are going to be better. Tooth decay is going to go away. And unfortunately, 90% of the adult world has had tooth decay. Nearly 20% of the adult world still has tooth decay. 15% of the adult world has severe periodontal disease, and another 30% has moderate periodontal disease. With everything we know, so tooth decay, for instance, is a wholly preventable disease.
Mm-hmm. You told me, yeah. We had that conversation, yeah.
Periodontal disease can be either controlled in non-smoking, non-diabetics. If we look at the two highest risk, predictors in there, with good home care and proper education for the patient and proper care, we can keep most teeth forever.
Correct. And which brings me to that very important, you mentioned it before, it's the aging population.
Yeah.
And right now, this is not anymore a talk. It's like the climate change. We talked about it for so long until it hits us now with this amazing rain and whatever it is, or fires or whatever. So now it's taken us by surprise, not by surprise, we heard it, but now it is a reality. In 2025, all the baby boomers will be 64 and above, and they're going to live longer. They are somehow healthier and not, so they have those two. But we know, as you know very well, if you dealt with a lot of different global events yourself, you know that the aging population will require more maintenance. That is the biggest problem. And that's why I turned into this, because you're talking periodontal disease is non-curable, but it's containable, like diabetes. That's why the correlation between them. So how can we, they're going to be on a budget. They're going to be living not like before, because they're not working. They cannot afford going and spending tons of money, and we see it. I mean, I have practices, the aging populations. So where is the role of the federal government, let's say, because like the governor told you, show me the money, basically, show me how it was the effect. But how are we going to do to help the seniors that they're going to live longer?
So we need to recognize, with the exception of the COVID bump, life expectancy has been going up. Unfortunately, during COVID, life expectancy leveled off, or actually in some cases went down for the aging population. America worse than some other countries. That being said, we are getting older with more teeth. The teeth that we are bringing into old age did not start in necessarily the fluoride era.
Correct.
They started long before that, and the periodontal enlightenment era, I'll say the 70s and 80s, where people started to realize that virtually every tooth was a savable tooth if we really went into this. And as you said, we can't reverse in many cases. So what's occurred is we're in an era where we are going to have people living longer with teeth that have suffered a little bit of the ravages of aging. And now we're going to have to figure out how to help maintain them. It's better to prevent the disease than to try and cure and fix the disease, whether we're talking about tooth decay or dental caries. It's better not to have the risk factors for oral cancer than try and treat and cure oral cancer.
100%.
So, stopping smoking or chewing tobacco, good idea. Controlling diabetes and getting regular cleanings, a really good idea. Those things are all going to be tremendous help to the future, and individuals in the future. That being said, the people today are arriving at aging with what they got, and what the sins of their youth are catching up with them. As much as we may hate the regular visits to the dentist, there's nothing better than the regular visits to the dentist, and particularly from the periodontal health standpoint, we shouldn't have bleeding when we brush. We should not have loose teeth. We have to get that managed and pay special attention. The expense, it's much more expensive to fix disasters than it is to maintain health. So, if there are people listening to this that are younger, get that. No, you can't tolerate when you brush your teeth having a little blood in the sink. That's automatically a fire alarm. Get that fixed and taken care of, and then maintain this throughout the rest of your life. You'll get to keep those teeth the rest of your life, and that's a big deal. Even implants, which we can touch on later, they're not the panacea of place and forget. You have to maintain this. Now, I will say that I'm disappointed in this world that in dentistry, if you get an infection in your finger and you're on Medicare is going to help you. That bleeding in the finger, that swelling in the finger, you can go see physician after physician, get medications, get surgery, whatever is necessary for that infection in the finger. They don't say take it out. They, unfortunately, in dentistry somehow, probably because of that evolution I spoke about, that we were outside the profession, oral health care is not part of routine Medicare. To me, that's terrible. Unless you're very poor, everything is an out of pocket on a person who's retired, and if you've lost the insurance from your job or you never had dental insurance, this is not the point in your life when you can take on some of the most expensive treatment. Correct. And so often, instead of fixing that finger that was infected, we see the recommendation in dentistry. Well, the only thing I can do that's less expensive than that is take the tooth out. You know,
And it is more expensive actually, because the replacement is more expensive.
and then comes the replacement question. You know, it's interesting. I think about a grandparent who lived into the 90s, and he always looked at, you know, well, you know, when he I started, I was in dentistry when he was, or getting near dentistry when he was in his early 70s. His line was, well, how much longer am I going to live? We don't know what's written in that book for us.
Correct.
I mean, you know, so I see so many, or I saw, like I said, I don't practice as much, but I saw so many aging patients that looked and said, well, you know, how much longer do I have to live? Just take it out. I've only got another 5 years. In 5 years, they're coming back. Why is this tooth growing down on the top? Or why are my teeth dipping? Or I can't chew well over. And now it's become even more complicated. So, you know, we don't know how long we're going to live. And it is much more enjoyable being in your 60s and 70s and 80s with your own teeth than missing them. So, you know, I have to say it's important to do that maintenance and keep them healthy rather than the more expensive route. And I think for our government, when we look at quality of life and the complaints that an aging population has, a little dental care would go a long way for a lot of people in making them feel better. And we, unfortunately, I don't see this. I wish it would happen. I don't see it happening for our patient population in the near future. I wish I did.
Yeah, that's so. With the aging population, there's one more, and then we will move a little bit on other social issues. With the aging population, we have, especially for female and even male nowadays, that they are getting osteoporosis. One of the other issues. So many other things, but let's focus on this, because this is, I just dealt with it literally 10 minutes before we get on to it. And you know, physicians are quick at saying, or endocrinologists, rheumatologists, and I am not criticizing them. I don't want them to think that I'm criticizing them, but they jump into give them reclass. And for the non-medical that listening, reclass is a very heavy bisphosphonate medication. It's infusion. It lasts for a year. Its half-life goes 10 to 15 years, meaning the degradation takes very long, and it's a compounding effect. So the problem for us in dentistry is somebody has a chronic disease or has a cavity, they're going to have a surgery or extraction or so on and so forth, or root canal too. So the risk is to have that, what we call the osteonecrosis of the jaw, or NJ. And that means bone exposed never heals. The treatment is not secure. How can we get, again, I'm going to go back to the same point. How can we get those physicians to clear the patients? Like, we clear them before we do any procedure in gum and implants and periodontal treatments, but yet they don't try to do a clearance for the dentistry. So what is your word of wisdom on that?
So this is I've spent a good deal of time dug into the science of this. I actually helped in a study. I was a participant in a clinical study of the incidence of we used to see this only when patients had radiation therapy, and in as the incidence of these drugs used for, in some cases, cancer patients, but in most cases, patients that were developing less bone density. And just as a commentary, they work by preventing your own body from resorbing and remodeling your bone as quickly. You were resorbing it quicker than it was depositing. And the net effect is the density of the bone becomes less. As male and female get over the age of 80, we almost equally face this loss of bone density and an increased risk of hip fracture, particularly bones that break almost spontaneously with a fall or with a twist. And the really bad news is these fractures, life expectancy drops radically right after those events because of the healing, the lack of mobility, the chain. So having to do something to prevent this osteoporosis, and it starts out as osteopenia, where you're just slightly less dense than you should be, but it's heading in the wrong direction. And physicians manage this with addition of calcium in the diet and vitamin D to make sure it's being absorbed well and things like that. When it gets really bad, they decide, okay, let's stop the resorption and see if we can stop this density loss. The disadvantage for us as dentists is when that occurs, now we have the problem that doing any surgical procedure on the mouth that involves the bone, we don't see healing as well afterwards because the bone has stopped remodeling and resorbing the way we'd like. And some patients even get spontaneous breakdown of the bone, and it's a spontaneous breakdown. So now comes that risk benefit, is the benefit of taking the drug and not having this risk of hip fracture more important than the risk of creating problems with dentistry. The biggest reason why our healthcare providers are not as easy to get answers from is the literature is not parsed as clean as we would like. So you did just mention that some of these drugs have half-lives of 6 months. It means the patient comes in with an abscess and needs a tooth extracted. They have an abscess, they're going to need a tooth extracted. Leaving the infection, leaving the nidus, leaving where it started longer may actually increase the risk of infection in there and damage to the bone. Right. So we as dentists, unfortunately, wind up in a very hard spot caused by this. And I think one of the most important things we have to do is help educate the patient. When we take that tooth out, Mr. Jones or Mrs. Jones, when we take out this tooth, unfortunately, because you've been on this medication for so long, we may have problems seeing you heal. If we do, we may have to be more aggressive at getting the tissue to come together and heal. This is problematic, and we don't know who's going to have the problem.
Correct.
You can't wait for 6 months or a year, with an infection or. So I think a little bit dentists are asking the physician to give them a clearance for something that the physician knows wholly that there is no magic clearance I can give you that's going to make this work better. It's not like there's a pill I can take or an antibiotic I can take that's going to guarantee this is not going to happen again. But that being said, I think coordinating in many of these cases, stopping treatments that patients are taking currently helps. Waiting a couple of months sometimes to do certain things, clustering what we have to do and getting it done and not stretching it out, special care for taking care of the tissues and management. We stand a chance, not a guarantee, we stand a chance of improving the outcome for the patient. And I think that's just very, very important.
Yeah. No, you couldn't have said it better. And hopefully in future, you are a pioneer in electronic health records. So I hope that you can help us probably bridging things even better through that. I don't know. It took me a whole day to get one phone call back from a physician, for instance, on that matter. So moving to a last part that I know it's very important to you on a personal level, meaning how can we help underserved. And I know you have another topic that is very, very, very precious for you, is the people with disability, which you've done an amazing work on them. But let's talk about the people that, there's two. There is the poverty, and we have in the United States a huge amount of poverty. For some reason, we forget about that. If we look at the southern states of United States, which is the most rampant in periodontal disease for some reason,
and tooth decay.
and tooth decay, and across the races, has nothing to do with color.
Yes.
And yet we brag about doing outreach outside of United States. We're doing this, there, and that, but yet we forget that we can do outreach inside, domestically, along with the outside. I'm not saying we shouldn't be helping outside. I don't want to be misunderstood, but in your position as a dean, that very, very proactive in that matter, how can you give an advice for people that want to help in this, and how can we do it better to serve these people and create a sustainable programs to not only go there, do them a little bit and disappear?
So let's recognize that there are areas of the country that are dentist deserts. They're health profession shortage areas. Their nickname is HIPSA. Those are real hard areas for me to make recommendation on, because they, even if they're they tend to be poorer, more rural, less dense, and there aren't adequate numbers of dentists to deliver the care that would be needed by the community. In the non-HIPSA areas, so you said, we talked about persons with disabilities. Which, by the way, if we live to 80, 1 in 2 of us will have a disability that interferes with our activity of daily living. I hope we all live over 80, and I hope we all stay healthy. But, we need to be conscious of this, that this could be us, it could be our parents, it's our family, the people we love. I practiced in an affluent community and I was blessed to be able to do very high-end aesthetic dentistry and implant dentistry. But I paid attention to children that were from parents that did not have the resources. I made sure to address the community that has disability, whether or not there was finance, and never thought about the fee that would be associated with this. And it was out of a sense of community. These were anybody that was coming to my office was somewhere around where I lived, and that society, it's the sense of charity, it's the sense of community. That's what it was to get and deliver care. And we did this for what they could afford to pay. I did it frequently for no fee, because I was very committed to seeing to it that individuals get the care they need to get to stay healthy. That's not to say I would put in implants and reconstruct a mouth, but I'll see to it that the person doesn't walk around with infection and things like that. If every dentist took a small piece of that obligation, this would be I think it would be a friendlier world, because people would see the charity and health and things that we get to do. But most important for me, I think that would establish us as a giving and holistic profession, caring about people. I always applied these metrics to the patients, the family of my patients that had been with me. It's not to say I opened my doors and said, bring me your poor and huddled masses that can't afford dentistry. I'll do that for everybody. In my case, I was in Suffolk County, New York. That's not what we did. But I never hesitated when a patient said, you know, my mom and dad, they live nearby, they can't afford, bring them in, we'll figure it out.
Yeah.
And we always did. I think those were my most gratifying. It made me feel the very best.
Yeah, I mean, I hope that you can influence this new generation, because unfortunately it looks like, based on the studies, that it's a little bit more self-centered. They're not into looking around.
They come out with debt, and they come out with, but I think we at Penn which is not an inexpensive dental school, are having and driving an effect with people understanding the value of doing community service and working in the lived experiences of patients and how we can improve their overall health. I think we're making a difference in those areas.
Yeah, and I heard you talking about these community centers that you opened, and you get the fundings for them. That was very commendable. That's why I brought up this question. I hope a lot of people will follow suit like yourself. And that brings me to the last subject, and subject that you know, we've talked a lot about recently, about racial disparities. This is something that I've been studying a lot in the healthcare, but there was a study that came out in JAMA, in Journal of American of Medicine, and in 2023, it was a very interesting paper, and they said that if a Black patient been treated by a Black physician, their chances of survivability increases. So it's striking. It's something I was not happy to hear, but because I thought that it shouldn't be related, but it seems in the Black communities and in the Hispanic communities, it has a big impact. So how can we, as I worked in training and recruiting dentists, and we've talked, me and you, about it many times, that I wanted to have an African-American student, and I couldn't have one in my 10-year as except when I was at Lutheran. How can we encourage this population of young Black men or women? They are dentists, or they want to go to dentistry, or Hispanics, which there is quite a bit, but to specialize probably. How can we get them to be motivated? Or there is a role for the dental schools to do that? So please tell us about that.
I think there are multiple ways that we have to approach this. So the area, every person comes with a personal bias inside them as we look at anybody. And, you know, one of the things that they have seen in emergency rooms and other, if a physician is caring for a patient, it's important that they not look through the lens of their personal experiences that may have bias in it, but more important to make sure that we're always listening to the patient in a culturally sensitive fashion and treat the patient in that culturally sensitive fashion. So part of that is making sure that all of our healthcare providers get immersed in lived experiences of persons that are very diverse in cultural and economic backgrounds, and that's very, very important. When we're talking about trying to make healthcare providers that look like our nation with the same percentage, and I think this has to start very young, and we have to make sure that first there are some role models, which is hard if there's nobody, but we need to have that conversation. We have to see to it that all young people have the ability to have that science, technology, and engineering, mathematics education, and learn to value that. So they go to school, their people have the opportunity to get advanced education and be even qualified to come to a dental or a medical school, a healthcare school. So I think we have to start in the high school pipeline and make sure that our student bodies are getting good education in our center cities and our rural environments. I think that they need to have good science, and we have to keep them in science. One of my largest disappointments was my oldest daughter looking at me and said, "No, I don't want to take physics, Dad. That's not going to happen. I'm never going to use that." Well, as it turned out, she never did use it, and she survived quite well without it. But when people make those decisions very young, there are things that we know that I knew that my daughter will never be able to be a physician or a dentist because she wouldn't have the science education to get into those programs. And I think we need to make sure everybody understands their value and can see the value in getting the education. Then once they're in colleges and doing, I think it's so important for our dental schools, our medical schools, our professions to literally get out and speak to people about, this is a profession that you can enjoy and you can help, and all the things we talked about earlier, you can affect a person's life, and this is your opportunity.
Yeah. Well, Dean, we can spend hours talking. Now people know probably why I love to spend time with you. I want to really thank you for giving me the time for this podcast. I'm sure everybody enjoyed it or will enjoy it when they will listen to it. And I hope that people have listened in the position of change and that they can influence. And thank you so much. I really appreciate it. And I look forward to see you in person in coming weeks.
Soon enough. I wish you peace, health, happiness for everybody, and lots of smiles. It's good stuff.
Indeed, indeed. All righty. Well, thank you so much.
Thank you.
All righty.